I'm going to talk about airway management in critically ill patients. This was meant to be done in December because we did a December. If any of you were in person at that point, I remember some people coming around with people using cake and stuff, teaching about the new DAS guidelines and airway management. And I was supposed to do it then, but stuff kept happening. That gone away. I think there was a junior doctor's strike. So, yeah, it was meant to be in December, but you guys get to benefit from it because you get to do it. So, I wouldn't class myself as an airway anaesthetist, although that term slightly irritates me because all anaesthetists do airway stuff. But I went to the World Airway Management meeting in November. That's how I ended up doing this, because I went and heard the new DAS guidelines be presented. And I mostly did that because it was in Florence and there was a good group of people going. I was good at social something. But I was like, I'll probably do something else. So we are going to talk about the 2025 DAS guidelines, which for the non-anaesthetists amongst you is a difficult airway society. For the anaesthetists amongst you might be aware of them already, or at least probably should be. But there's a specific bit about critically ill and call it physiological difficulty. Talking a bit about human factors and just a bit about how to intubate critically ill patients, because it can be quite challenging sometimes. So, NAT4, which was 2008, which is really a long time ago, but that was looking at major complications of airway management, and a significant proportion of those were in ED and ICU. In last year, NAT7 was looking at cardiac arrests under anaesthesia, and quite a significant proportion of those cardiac arrests were still airway management and ventilation. So 17 years later, not much has changed, basically. On ICU, there's a failure of first-pass intubation in about a third, which is quite a lot. And about a quarter of them get severely hypoxemic if they're tubed on ITU or in ED. And severe hypoxemia is less than, they defined as less than 80% stats, which happens quite a lot, particularly because you're usually tubing them because they've got respiratory failure, they haven't got any reserve. So. And then apparently about 4% of patients nationally are admitted to ITU for an airway problem, whether that's to watch because you're concerned about their airway losing their airway or getting worse, or they're in because they've had to be tubed for an airway problem, whether that's like epiglottitis or nasopharyngeal abscess or something. And actually, most incidents on the unit, like 82% apparently, happen not at intubation. They happen after the airway's been secured on ITU at least. A quarter of those lead to death, and that's probably because the tubes are in for such a long time. It kind of the actual tubing is only a few minutes, whereas they're in for days and weeks sometimes. And those airway incidents include airway displacement or kind of blocking the secretions and stuff. And trachees have the highest risk of those things going wrong. So just because somebody's got a trachea does not mean that they are safe, particularly in the first few days, and they do get dislodged and people die from it. So on ICU and in ED, any non-theatre environment where you're inducing somebody and putting a tube in, there are lots of challenges. Staff find it difficult. So all the equipment is not the same as what you're used to in theatre. There's all the monitoring, all of the airway kit that you've got is in different places and in slightly different things. You probably don't have an ODP a lot of the time, not on our unit anyway. And so people don't think in the same way that you do as an anaesthetist. Not everywhere you work has got out of hours airway cover. I think most places do now, to be honest, at least in the UK. But certainly not everywhere uses capnography. I have to argue with them sometimes to get it done. Have capnography at the journal. We don't do airway training very often in ITU. Probably they don't do it in ED either. Most of the patients that we tube are higher risk, so it's not a very good place to learn, to be honest, if you've not done it much before. So you don't get the opportunity to learn properly on the unit. And the same with the nurses, they don't get the opportunity to learn, they just find it and it's all gone a bit wrong.
So they don't have capnography at the general sometimes, and what contexts?
Wasn't actually.
Okay,
You have to specifically request that they put capnography. Just pressing.
Talking about the HD, they have it now.
They have it usually now. Yeah. What else there is. So patients are higher risk on ITU or in ED. They're usually not fasted. They're usually critically ill. That's why you're doing it in the first place. So they've got gastric stasis. They may or may not have an NG tube, so at higher risk of aspirating. They have you have less time for planning often because they need it now or within the next few minutes, so you can't think about it as much as you might want to. And then physiological difficulty is what they call it, when there are other things about the patient that are causing problems. That might be physiological or pathophysiological, to be fair. So physiological ones are older age or pregnancy, children, obesity, because they have less reserve generally. And then any kind of pathophysiology, so any edema or trauma to the neck, if they've got C-spine immobilization, that makes it more tricky because you just can't move stuff. Pre-oxygenation can be challenging, especially sometimes in ED when they're delirious and all over the place. Getting them to stay still long enough to get any oxygen anywhere near their face is sometimes challenging. Same with positioning. But sometimes getting a pillow is almost impossible. Respiratory physiology, that might be why you're tubing them in the first place, because they're struggling, they've got respiratory failure sometimes, so they haven't got any reserve to be able to prevent them from desaturating. Bronchospasm, if you're tubing a critically ill asthmatic, then that's one of the scariest things we do, I think. And it's very unpleasant. That's a different talk though. CVS physiology, so again, that's probably the most common thing that goes wrong when we're tubing critically ill people, is they are hemodynamically unstable. And the drugs that we give, so 200 milligrams of propofol that you would give in through a day case in theatre, you will make a critically ill patient arrest. So don't do that. You need to think about it. And the other problem is, if you fail with your airway management and you put them to sleep because they're critically ill, you usually can't wake them up again. There isn't a way out in the same way that it might be for a day case elective patient. So it can be challenging. And then challenges just from being in a different place. One that I hadn't really thought about, the bed spaces on ITU or ED are not really designed for airway management, because the monitoring is behind your head. They're designed for standing at the foot of the bed and looking at the patient and the monitor at the same time, not for standing above the patient's head and not being able to, you can't look up. Which I'm kind of aware but hadn't really thought about. There's always lots of stuff. The lighting's rubbish. It's not as bright as it is in ED, especially if you're doing it overnight. The equipment will be different to what you're used to in theatre, if that's where you learnt, which is where most people learn. You don't have consistent people that are practiced in being the airway assistant, or are used to a specific role. They have the nurses on ITU, or they're very good, but they are not ODPs. They don't think in the same way, and they have very different priorities. Same with the ED nurses. DART help a bit, but again, they're not ODPs. They're more useful than others, but they're not the same. Transfers up from ED or to CT or to another hospital often get delegated to the more junior staff, which is a good way of learning, but it can be a bit terrifying if it goes a bit pear-shaped, then you end up on your own. And doing the airway assessments in critically ill people is, again, really challenging. They might not cooperate, they might not be willing or able to open their mouth for you. You don't have much time for doing any of this stuff or looking up in their notes whether they've got a difficult airway alert or something. You might find out just by putting the scope in and go, oh. So, this is the new DAS algorithm, which, to be honest, is very similar to the old DAS algorithm, but with kind of little tweaks here and there. There's still plan A, B, C, D. I mean, hopefully you do plan A and that works and you don't have to go, which most of the time you will, but sometimes we get down further. So I'm going to go through each bit of the algorithm separately because it's busier when it's like that. Do one plan at a time. But the first bit is preparation. So you've decided you need to tube this critically ill person because they're unstable in some way. Whenever you do it, it's going to be high risk and scary. So your risk assessment is kind of, this is bad. Well, how can I work out what to do about it? But actually, the risk assessment for airway management there is a specific ITU assessment, which apparently has been studied and checked, which is the McCutcheon score, which you can do in just a couple of minutes. So you get them to open their mouth, try and work out what their Manapati grade is, which is how much of their soft palate and uvula you can see. 1 and 2 are normal, 3 and 4 are harder, basically. If they've got OSA, you probably know that from history. It usually gets mentioned. If they've got a C-spine problem, particularly in ED, particularly if they've got a C-spine injury, they're going to be you're doing inline stabilisation as well. Just ask them to open their mouth. If they can't open their mouth very far, then that's concerning. Are they unconscious or are they really hypoxic? Those are higher risk. And it's higher risk if it's not an anaesthetist doing it. Although you can be perfectly competent in it, it's just that it's not necessarily what you always do. So you're trying to predict difficult intubation. If they score 3 or more of those, which quite a few of our patients probably would do anyway, those are high risk, and you should think about ways of trying to mitigate that. The other thing that you can assess for is a difficult mask ventilation, and the easy things to look at, you just look at them and go, are they big? Do they look like they've got OSA, or do we know that they've got OSA? And do they have a beard? Their facial hair. That also makes it more tricky. Other things on there. You can, if they've got an NG tube, you can suction down it and try and aspirate stuff the same way that you would in theatre doing an RSI. Make sure you've got your suction ready and under the pillow. Pre-oxygenation, you can do it with a tight-fitting mask and a bit of PEEP. Or you can use high flow nasal oxygen if it's available or if you're already using it, and then you can use your high flow nasal oxygen during your intubation attempts as well, which is what they call peroxygenation, so that can be quite helpful. They should be sat up, unless you're worried about C-spine trauma or something, but otherwise sit them up. Having been the person that's lying flat on the back with everybody leaning over them doing the WHO checklist, even though I knew most of the people and knew what they were doing, it's really intimidating to try and sit them up. Also, it increases their FRC, so it's going to prolong the length of time before they get hypoxic if they can be sat up. Hemodynamic stability I've kind of mentioned. It's the most common problem in critically ill people, and you're going to need to plan for it. Ideally, allocate a team member who can independently keep an eye on the monitor and manage that for you. Don't do this on your own, some people are unstable. I wouldn't do it on my own. I'm sure most of us wouldn't if we could avoid it. So get somebody else that can give fluids or base pressors independently without the airway person having to watch you do that as well, because you get distracted with doing the airway. So give them some fluids, give the induction agent and then flush them with phenylephrine as well. Start some peripheral NORADs, that kind of thing. The other thing that the DAS guidelines mention actually in the risk assessment bit is if you think somebody's going to be really difficult, get them to extend their neck and then feel for where their cricothyroid membrane is and mark it on their neck before you start. Because it will be one less thing that you have to think about if it gets that far and you get stressed about where that is. And you could do, if they've got airway pathology, you could do get ENT to come and do a 5-day endoscopy and have a look, just to give you an idea. And then you need to collect drugs. So, what drugs do you use for tubing critically ill people?
Resuscitation drugs first.
Like?
You need to keep atropine with you and adrenaline.
Yeah, okay.
Induction agents.
What induction agents would you use?
Entirely depend on the patient you're intubating. What are the hemodynamics?
Yeah. Okay.
So the commonly one we used are the propofol, that you need to have indication.
What muscle relaxants do you use? So everybody uses that.
I used that for the first time in 5 years.
Is that the answer?
And the manners to that? So yeah, okay, so if we do muscle relaxants first, rocuronium seems to be becoming much more universal, mostly because Sigamadex is available. Just remember, if you think somebody is high risk and you want to think about giving them Sigamadex, if you've given a big dose, an RSI dose of rock, 16 milligrams per kilogram of Sigamadex is many ampules. And it will take some time to fill up. It's difficult to do in an emergency, actually.
And they don't have it in research, do they?
I don't think they do.
So we always use it rock.
Yeah, I think that you have to argue also as well, but many people think to stay because they're like very unwell, you know, and they have like, you know, some sort of like respiratory failure, and probably to reverse them, it will not change much. I think that you really have to go down your algorithm.
Yeah, that's
Because
right.
again, yeah, so.
Yeah, that's why I said at the beginning, actually, you can't,
There's no point in waiting up.
if you can't wake them up,
Yeah,
that's not an option.
yeah.
And it actually doesn't matter if they,
Yeah.
that it takes ages to hold you down. Sux does have quite a few side effects. The anaphylaxis one is about the same for Sux and for rocuronium, I think. So, but there are lots of other side effects with Sux as well. But it does have a short duration of action, so that can be both good and bad, because if you fail with the first couple of intubations, the success started wearing off, and then you have less good intubating conditions anyway. Induction drugs, I just wrote a list of some I can think of. I have used all of them. I haven't used accommodate off my own back. That was a cardiac anaesthetist.
Yeah,
routine,
one
but,
specifically.
yeah, and like you said, it completely varies depending on what the situation is with the patient. And if you've got somebody, if I've got somebody who's got come in with a head injury or a suspected subarachnoid hemorrhage, and I mostly want to think about blunting the hypertensive effects for laryngoscopy, there is 5 milligrams of alfentanil in ED, or there always used to be, I think it's still there. So I would get 5 milligrams of alfentanil, give them 2 milligrams, and then give them some propofol and some rock and probably some phenol just to make sure it didn't dump too much, and then stick the rest of that alfentanil in the propofol syringe for my sedation for transfer.
Sorry, you will give 5 milligram of alfentanil and what else?
2 milligrams of alfentanil and some propofol, however much they need. They probably don't need very much because you're doing it because they're unconscious. So like 5 mils or something. And then some rock, and then put the other 3 milligrams of alfentanil in the propofol syringe for transfer sedation.
Okay, all right.
Because there isn't any remifentanil downstairs, so it's an easy way of getting some opiate. If I've got somebody really septic, we had one at the weekend who was really septic and already on noradrenaline and looked like he was going to crash when we tubed him. And he got, I don't know, 2 or 3 milligrams of midazolam, probably 200 mics of fentanyl, and they're already asleep by then. You can give them a mil or two of propofol to make yourself feel better, but they're already asleep by then in a fairly cardiostable way. I think actually because in his case, he was so tachycardic and hypotensive, his sympathetic nervous system was working really hard already and not doing enough. Giving him ketamine would just have made his heart work even harder and probably would have ended up more hypotensive, to be honest. Might have arrested from it. I do like ketamine for the bronchospasm patients, though. That works quite well. A fixed dose of ketamine is probably safer than a fixed dose of propofol. That's why they like it in pre-hospital and in ED, because it's a bit safer. But a bit of opioid and a lot of opioid and a little bit of induction agent usually works quite well to keep things stable. I like trying to get away with how little propofol I can get away with. I can usually get people to sleep in theatre, but for elective stuff, but I can usually get people to sleep with 10 to 12 mils of propofol. If you just go it really slowly, it's quite fun. Now I'm sad, but anyway. Any questions about drugs? Or any way that you would do it?
I always think a critically septic patient definitely would not want to use ketamine. I'd rather feel more safer with midazolam and any combination.
I think they get worse with ketamine.
Why do we not use ketamine?
Because ketamine is actually inherently a myocardial suppressant, but before it does that, it actually releases all the noradrenaline and adrenaline. If all of that is depleted, what it does is myocardial suppression. You end up patient who is more hypotensive, and you never know in a septic patient where he is on that on that path.
And why do we use ketamine?
So why would
Why are you not?
It's a central sympathetic nervous system activator. So already you're already running cardiac dose.
They can end up a lot worse.
Unless when you're giving your drugs,
Yeah.
do you give your induction agent flush and then immediately give your muscle spasms, or do you wait for them to close their eyes and look asleep like you would in theatre?
Yeah. I usually wait. Rock your ring hurts.
Yeah.
I mean, usually the critically ill ones don't remember any of it, to be honest, but some of them might.
Especially if you're using ketamine.
And yeah, ketamine takes a really long time.
And where would you use sevoflurane?
I just wrote that because I couldn't think of it. I was trying to think of drugs.
It's actually good in a critically ill asthmatic.
In asthma, yeah.
It's very good.
There is a Zero vaporizer in A1 research.
Yes, yeah.
Yeah, there is.
But
And maybe 12?
What was that?
A1 and 12? They were the two piece ones, weren't they? On the left is you go by the PTD. There used to be. There is at least one. I've never induced somebody out of theatre with sevoflurane. But for a life-threatening asthma, I'd probably induce with ketamine and then maybe put the vaporizer on if I happen to be in the right vein.
How about the conditions like acute epiglottitis or laryngeal mass where you pending airway?
Take them to theatre.
Yeah.
Don't do it in ED. Take them to theatre, have ENT there. And what would I do? I don't like, I know the textbooks always say gas induction
Gas
for
induction,
those,
yeah.
but I think people are going away from that and I've never done it. I don't want to. I would, yeah, do IV probably.
Have ENT side.
Have ENT there, yeah. And then video laryngoscopy for go. Oh, cross your fingers. Okay. So, in your preparation bit, you trying to get things ready. Make sure you talk to the team and work out who's doing what. Check you've got all of your stuff, and make sure that you've got plans so that people know where what your plan is, what plan A is, what plan B is. And you get all of that if you do the LOCSIP at the time, so that people know who everybody is, feel a bit more comfortable to speak up if it's going on. There are bits of paper around, so that's the idea of them. So please use them. Okay, so plan A is give tracheal intubation, and there's a maximum of 3 attempts. And then if somebody more experienced comes along, they can have one go. That's the idea. There is, so if you there is a thing called peroxygenation. So they want you to keep giving oxygen during your intubation attempts. If you've got nasal specs, they stick the nasal spectrum to 15 litres. Or if they're on high flow nasal oxygen, then you can carry on. Continue with that. You do have to keep, if you're trying to face mask ventilate in between, then you do need to keep taking the thing off, but because you can't get a seal otherwise. But the high flow nasal oxygen does actually work quite well. It gets quite a lot of oxygen in, which will obviously save apnea time. Cricoid pressure is recommended. There have always been lots of concerns about it as to whether it worsens the view, makes it less likely to get a tube in, might not actually prevent aspirations, but there's not been any evidence found for any of those things, and it's been found not to reduce kind of first attempt and overall intubation success with video laryngoscopy. So it is advised to continue to do it in patients at high risk of regurgitation aspiration. The other way of doing it is to get them sat up a bit, which I've already said. So, DSI is delayed sequence induction, which might be necessary for the really agitated ones that you can't get anywhere near. Stick a bit of sedation in so that they lie still long enough for you to hold a face mask on them. Ideally, you don't have to make them
completely unconscious, but if they just stay still long enough to get a bit of oxygen somewhere near their face for a couple of minutes before you actually do the proper induction dose, then that would be helpful. But actually, the first thing in there is to say that everybody should use a video laryngoscope as first pass in all airway management, whether ITU or not, actually. It does appreciate that that's not going to happen in the UK because we don't have enough video laryngoscopes, but all of the video laryngoscope companies are really very happy about this guidance because they're now running around trying to sell as many as possible. So we currently have the McGrath, but we are currently or have been trialing different ones and might be getting more different ones very soon. The advantage of the McGrath is it is the same shape as the direct laryngoscopy, so you can look with that as well as look at the little thing if you want. Just be aware if you are using a video laryngoscope that you get a nice little view. But your view is at the end of your blade. So when you just because you have a nice grade 1 view on the scope doesn't mean that you can get the tube there. So use introducers, use your bougie to kind of aim it. You probably want to get a grade 2B view on your McGrath scope to get to get the tube in as easily as possible if it's vaguely straight. Make sure that they are properly neuromuscularly blocked because that optimises intubating conditions and makes it most likely to succeed. And ideally keep an eye on the time, know what time you gave drugs, maybe allocate somebody else to keep an eye on the time for you so you're not there for a really long time. And you can try use introducers. Some of the hyperangulated blades, like the glide scope or some of the other CMAX and stuff, come with their own stylets that are the same shape. You put it on the inside of the tube and it's the same shape as the blade, which might be useful. You can get your airway assistants and move the larynx, which if they can see on the screen, they can see whether they're making it better or worse, which might be quite beneficial actually. And you can try removing the bicoil and see if that makes it better. If it works, then check for capnography. Whether there is end-tidal CO2 on your capnograph. If it doesn't work, then you should, like I said, try 3 attempts plus 1 for somebody else arrives. And each time you try another one, you should change something. Whether you change your blade, optimize the position, make sure that they're properly blocked, neuromuscularly blocked, that kind of thing. And if it doesn't work, then you need to declare failed intubation. So say that it's not worked. Say that you have had a failed intubation, so that everybody knows what's going on and kind of moves on to the next bit. Which would be plan B. You should have called for help by now. If not, then call for help. And again, a maximum of 3 attempts. Try putting in a supraglottic airway device, whether that's an iGel, which is what we use in this hospital, but there are other ones available. Second generation ones tend to work better. They tend to have, they fit better and have suction ports and stuff. Again, make sure that they've got adequate neuromuscular blockade. So this is if the EU stuck, so it's probably worn off. Again, change things between attempts. So change the size or change the type of supraglottic airway device. if it works and you're able to get gas in and out and their stats improve, then you can stop and think and work out what you're going to do. Because there are various options that you can do. That you probably can't wake them up. But if you've got the airway in, then you can wait for somebody else more experienced to arrive and try and come up with a plan. Or you can do fibre optic intubation through the Agile, which I've never done, but I feel like it should be doable.
Or wait for somebody else to arrive and do that. If you can't oxygenate them with the iGel or whatever else you're using, again, say that this has failed, and so then you move on to plan C, which is your kind of last resort to avoid stabbing, which is face mask ventilation. So you need to optimize the position, probably use two-handed technique or two-person technique, and airway adjuncts and stuff. And see whether you can get capnography and improvement in oxygenation that way. Be aware that if you can't, you are rapidly going to progress to plan D. And it's probably going to be more difficult, even if you could do face mask ventilation at the beginning. By the time you've done airway manipulation and trauma and stuff, they might have trauma and bleeding or swelling, and it might actually be very difficult or impossible to do face mask ventilation. So again, if that doesn't work, you can't face mask ventilate, then just say cannot intubate, cannot oxygenate, and to move to plan D, which is why I've got that thing, so we can play with that anyway. Yeah, so this is why if you're really worried about it, then you can work out where their cricothyroid membrane is before you start doing anything. But get their neck as far extended as you can, and it's take your scalpel, do a vertical incision across the cricothyroid, where you think the cricothyroid membrane is, while holding it with your other hand. Blunt dissect with your fingers down to the cricothyroid membrane, and then do a lateral incision or do a stab incision with your scalpel blade, which should be a size 10 scalpel. Once you've got that in the trachea, twist it through 90 degrees. So you've gone in and then twisted it, and then you can pass a bougie through that hole. Take the scalpel out and pass a size 6 tube over that bougie, and then hopefully you can oxygenate them. Just be aware you're putting a size 6 bougie, size 6 tube in here, not here. So it will, if you put it in as far as you normally would, then you will end up enterbronchial, and their sats will still stay low probably. But just keep an eye. And then once you've done that, try and stabilise the patient, and then work out what to do next. Probably get ENTs to come and put a formal trachea and get the patient to theatre if you're not in theatre. And then work out what to do safely. If you can't get it in, you can make the incision a lot bigger, and you can do basically the whole neck, dig around until you find trachea somewhere, or get somebody else to have a go if it's not working. I've not done it.
It happens once in a career, apparently, but having to do it at an incision all the way up.
Well, no, emergency don't know.
I don't really want to.
We'll just choose you, I guess. Not like, yeah.
The other thing to try and remember through all of this is if you've given a bolus dose of propofol or whatever at the beginning, this will probably take 10, 12 minutes. That bolus dose is worn off and they'll be paralysed if you give them rock. So you need some way of maintaining a bit of anaesthesia. Your assistant managing the hemodynamics can deal with that. Extra boluses of propofol maybe. Okay. So human factors bits. Oh, you alright?
Yeah.
Very just coming to listen. So human factors apparently happen. Well, human factors doesn't mean anything, but there are human factors incidents implicated in up to half of ITU critical incidents in airway management, which usually occur because people are doing not what it says on the algorithm, not really preparing, not checking you've got all of the stuff. The most common one is lack of situational awareness and not really being aware of how long it's taking or what the stats are or what else is going on. People get task fixation. And there's bits, well, the environment ones we've already talked about. ITU is not designed for airway management. Team behaviour, so leadership and followership are really important. Clear communication, kind of saying this is a failed intubation. What's really useful is to have a separate person, an airway person, a person managing drugs and hemodynamics, and a separate team leader that can maintain situational awareness if possible. I know it's tricky, but you should have at least 2 of you, not do it on your own. Yeah. Education and training are actually apparently the least effective control for improving patient safety, which is what's always said as the answer if something's gone wrong is to improve education, but actually design changes and mitigation to for protocols and environmental kit stuff are much more effective at patient safety than just education, apparently. So, I mean, I could stop talking, but vortex management and vortex. This slide is kind of 2 ways: cognitive overload and task fixation. You can end up in this massive spiral where you go down and down and down, and impaired decision making, and patients do very badly. But also, there is a vortex approach, which there's a website, vortexapproach.org, which is a way of thinking about doing your airway management and moving smoothly from one bit to the next in a kind of 3D way while optimizing each attempt. So if you're interested, go look at vortex approach to try and avoid the spinning badly. Yeah, so in summary, airway management in critically ill patient is really scary when it goes. They're all high risk. That's why you're doing it in the first place. Make sure you move through plan A to D, which hasn't changed that much, but it has a bit. Don't do it on your own, unless we do it on our own. We don't expect you to do it on your own either. Get somebody else. There's always the SRSD who's struggling. You need somebody else. Try and maintain situational awareness, which is really hard when you're doing a specific task. So it might be that you would be better doing the leading role and keeping the patient safe than somebody if there is somebody else there with you to do that. And do what you are comfortable with, not what not you're in ED and they want you to use ketamine, so you want to use ketamine, you've never used it before, or sevoflurane or whatever. Do what you are used to, and do it in a safe way, and that will be safer for patients if you do the things that you are comfortable with doing. And if you're not comfortable, then you should be phoning somebody else, whether that's the SR or the consultant or whoever. If you want to read more, there is the 2025 DAS guidelines came out last year, obviously, and there is a specific DAS guideline for management of tracheal intubation in critical ill patients, which is similar. It's older though, it's 2018. So it's, the guideline is slightly different, but the principles still make a lot of sense, and most of it's common sense. So all takes a very tricky.
Does anybody have any questions?
So what changed? What's the new data calculation?
Use video learning scope. And
I think the per oxygenation.
the pro-oxidation is much more specific. Yeah.
If you fail incubation, you should be opening your fauna straight away rather than waiting for the to go to plant D and then opening it.
That's also the old one, so for the critical illness. That has always like.
For the critically
been
ill
there,
one,
yes,
but for the generic ones.
Yeah.
For the, they call it priming, when if you fail one step, then you should be priming for the emergency front of neck, right from the.
Do we have front of neck access kit? Like, do we have it separately in our airway trolley? I think
It's in the difficult, that's one of the things is that the difficult airway trolley should be the same throughout everywhere. So the one that we've got on the unit, it's the same as the ones we've got in theatres and the same as the ones we've got in resus. And there is plan A, B, C, D, and in the D drawer, then yes.
these are there has been missed or something. I'll go have to look.
And what you need is a scalpel and a bougie and a tube.
It used to be a transverse incision for the fauna previously.
It used to be transverse. Now it's
Vertical one and then the transverse over the
Transverse to the microwave. Yeah. So it's vertical to try and make sure that you see as much as possible. They end up with
I think
skulls.
that if they're like thin, slim and stuff, you go, but if you see like someone who's like obese and then
Yeah.
But you
just from down and go.
if you had a failed intubation, they're probably not going to look like my neck, I think, to be honest.
Just practically, once you make that vertical incision, it's not going to bleed quite a bit.
Yeah, but if you just C comes after A.
But as in it's going to obscure your view, so you're going to have to quickly pause it and then.
Maybe a bit.
Together on the case, you know what to ask.
Exactly.
I think this was in an anticipation to increase the exposure and have a better view. But you're right, if you're reading, your view would be obscured anyway. You need to have a problem.
That bag is not, that bag is.
I'm pretty sure the bag has a front.
I don't say that I've looked in the bag, to be fair. Right. Oh, sorry.